has always been a country that's had significant fires. Ever since I was small growing up, we know that that's part of our summers. However, as with lots of extreme weather throughout the world, it's getting worse because of climate change. So the duration of fire seasons and the frequency of fires and the intensity of fires is dramatically accelerating in Australia. So we used to see our fire seasons would start in about November, December, which is our summer. Now they start in September. So already we're at the start of October, we have significant bushfires in Australia at the moment that are threatening towns and communities as well. So an escalating problem for us. 2019, 2020, we had catastrophic bushfires throughout Victoria and New South Wales, which are the states which have the largest population in Australia. Fires that burned for 3, 4, 5 months. 1 billion animals died. Countless communities were displaced. Many buildings burned down. Really significant. I think that was the point for a lot of Australians that kind of woke up to climate change has changed what we know and what we know about how fire impacts us as well. So this is a risk that is increasing to all of our communities, and particular to my research was how this is increasing the impact of risk on our hospitals. So I've just talked very quickly about the impact of fires on health systems. This doesn't equate perfectly to the Australian experience. As you can see, it talks about snow melt. We don't have a lot of snow in Australia. Do you have a little bit? But that's not what causes a lot of our problems. But I do like this diagram because everything down the bottom is kind of the things that we need to think about when there's a bushfire. So it's not just the smoke inhalation, the burns, it's also all of the destruction of property and how people are displaced and what that means for communities and continuity of care for chronic health conditions as well. So it's not just about the immediate effects. So the study that we performed used data from the My Hospitals database, which is our database for all public and private hospitals in Australia. In Australia, most of our healthcare is in the public system, but we do have some private hospitals as well. So we included all hospitals in Australia in all states that had inpatient facilities. Appreciating how important ambulatory care is and primary care. This is the first study we've done. We wanted to find an exclusion point. And so we chose inpatient facilities, and we chose facilities that provide less, they provide greater than 24 hours of care. So excluded those that were very short stay and only provided a day or less of care. Then we used R, QGIS and shape files from each state of the bushfire zone and risk, and then geospatially mapped and calculated the distance from the edge of each zone to each hospital. And then we determined that those facilities that were within a bushfire zone or within 500 metres of a zone were assessed to be at risk from bushfire. We had a total of 971 hospitals across all states after we performed our exclusions. One of the really big challenges with our study is every state in Australia defines bushfire risk differently, which is incredibly frustrating. And if you actually look at their methodology and how they've done it, a lot of them have used the same kind of input. So they've used vegetation and incline, but then they've come up with completely different risk systems. So some of them are binary, yes, bushfire prone or not. The state that I'm from, South Australia, goes to the next level and has high, medium, general, outback, regional and urban interface. And this made it very difficult for us to compare like with like across the country, but also serves as quite an important point, I think, to flag that we don't have that uniformity across Australia, and maybe that's something we need to look at for our risk assessment. So this is our results. The key things to take from this, and this is what it looks like when it's mapped out. So the red is close to bushfire zones and the yellow isn't. So Tasmania on the right-hand side. On the left-hand side, yellow is close. So that's Tasmania, where everything is in a bushfire zone because it's pretty much all forest. New South Wales is the one that's on the right-hand side. The city you can see there, sorry, that's Victoria. The city you can see there has a lot of yellow dots in it, and that is the city is further from the bushfire risk zone. As we go out into our rural and regional areas, you can see that a lot of those facilities are at risk. So we come back to this table here. One of the things we did, so initially we looked at high risk and we calculated high risk for everywhere. One of the things we noticed is particularly in those states that had tiered risk classifications, so South Australia is an example, it probably underestimated the risk to facilities. We know that during the 2019-2020 bushfires, hospitals and communities burned that weren't high risk. And so it's likely that when we're only talking about high risk, we are missing communities and hospitals that are at risk. So we look at South Australia, we can see that 4% of hospitals were at risk. When we go to the states that had binary classifications of yes or no, such as Tasmania, 100%, Australian Capital Territory, 90%, and Western Australia, 80%. When we adjusted for the difference in the bushfire risk zone mapping, and that's the highlighted yellow on that side, we can see that it evens out a bit. So for South Australia, we go from 4% to 75% if we include all risk zones. Of course, the states that have yes or no, they remain the same, but everywhere else went up when we included all levels of risk classification. And these are the states that had tiered risk classifications. You can see the change there, as I just mentioned. One of the things we did then was looked at the modified Monash model. So this is a model in Australia that looks at classifying different communities based on their remoteness and their population. So we go from MM1, which is the big cities, through to MM7, which is tiny little remote communities in the outback. And this was actually a really interesting thing to do because it really changed what the risk looked like for each state. So in South Australia, the highest number of facilities in South Australia are in MM5. So they are rural towns. If we look at that group, all of them are within 500 metres of a risk zone. So if we're looking at risk in that way, it becomes quite significant. These are hospitals that are likely to be the only hospital for their community. They are also hospitals that are geographically isolated from other hospitals, or if they are within some reasonable distance, then that hospital is a rural hospital that has workforce issues. That is a problem for us in Australia, that now has to cope with all of the patients and community coming from the hospital that's been affected by fire. So we look at the percentages there. That's what we've just talked about. So we're looking at New South Wales. Once again, MM1 has the highest number of facilities, but then if we look at the risk, it's MM5 again. So it's our rural and regional communities that are more predominantly affected. Queensland, it's the same. So almost uniformly across Australia, it's the regional and rural communities that are really almost 100% within bushfire risk zones or 500 metres of, and not the hospitals in the cities, which if you think about it, it does make sense. So we look at states with binary risk classifications, almost 100% of Victorian MM5 and MM6 are at risk, and the highest percentage at risk are in MM5, 6 and 7. In Tasmania, it's 100%, Northern Territory, 100%, ACT, 90%. And in WA, once again, it's MM5, 6 and 7 that are hospitals that are at really high risk. We look at the percentages. So if we look at across the top, we've got our modified Monash classification division. If we add it all up, 82% of MM5 facilities in Australia are at risk. So that's quite significant if we're thinking about what that means for Australia's regional communities and our planning for those communities as well. So they're often the only point of care in a community, and they may be the only hospital for hundreds of kilometres. So the impacts of bushfires mean that people need more care often. They need acute care for smoke inhalation, those kind of things. But they also need management of chronic conditions, access to medication, all of those things as well. And if you have someone who's displaced from a hospital because it's been evacuated, then where do they go and who provides that care? So it's really a flag, I think, that when we think about bushfire preparedness, which in Australia we've often thought about in a facility way or how do we evacuate our patients, we need to think about it in a regional context for our community. So this community, the hospital is closed, where do they go? How do we plan for that before it happens so we can provide good continuity of care for our patients so they can get care for their chronic disease, so they have their medication and they know what to do as well. So we're hoping that this study will really inform that planning and enable us to provide that more comprehensive risk assessment for our hospitals. So 55% of hospitals are within 500 metres of a risk zone. Highest results are in regional and rural areas. And as I've said, we need to include our regional risk in our contingency plans as well. Thank you. Okay, yeah, certainly.
So many health facilities that are in fire-prone zones, especially in rural areas, are there any interventions that could be done to actually, in some way, increase their local resilience, right? If there's a bushfire happening, obviously, if it's very big, it's going to sweep everything. But are there some, fire control measures or some additional measures that could be taken to reinforce and protect those facilities?
Yeah, absolutely. So thinking about the question was, what, if any, are measures that can be taken for hospitals that are in risk zones, particularly in regional areas, to protect them, create resilience before it happens? So I guess there's a few things. The first one is we're looking at infrastructure. Some of the new builds, they'll take that into account and so try and use fire retardant materials. But there is a lot of work that goes around backburning around the facility, making sure vegetation is cleared, making sure that if there are new builds, they're built in places that are likely to be less threatened by fire, although as we know that is changing. And we know that hospitals are often a point of safety for a community as well, so they'll go there. One of the other things that typically happens is that the fire service, and in regional remote Australia is the country fire service, so it's volunteer based, they will protect the important assets in the town. And one of the most important assets is the hospital. So you will get that as a priority for protection from fire. Of course, if it's a catastrophic fire and they're completely overwhelmed, then that doesn't always happen. And then I think the next step is to think about, okay, if the hospital's incinerated, then what happens? And think about that before it happens, but hope it doesn't. Mm-hmm. This does not end all that work. The way you have risk, the assessment is not important, but taking into coverage. Absolutely. So we have looked at, sorry, I'll repeat the question. So the question was around metropolitan hospitals likely to have greater coverage. We thought about adjusting our index to look at the contribution that they have to, I guess, the care of the population, and that many of them aren't judged to be at risk by the work we've done. I guess in regards to that, there's a few things. So we have looked at doing a sub-analysis based on that, an exposure rate based on population. One of the reasons we haven't done that yet, and I guess I'll backtrack a little bit. This work is based on work that was recently done in California where they did do that. And they looked at the number of beds that would be affected by proximity to fire. One of the reasons we've taken the kind of direction we have is having a look at the metropolitan hospitals. Now, yes, they have many more beds and they cover a huge amount of the population compared to our regional hospitals. But if we look at their location, they're almost all predominantly in the middle of really big cities. And the chance of them actually being affected by fire is actually quite low. I say now, today in 2023, who knows in 10 years' time. But it really is quite low. And when we looked at the distances are actually quite great. So they're 10, 20, 30 kilometres away from any kind of fire risk zone as well. So certainly would be worth looking at. But I think in terms of the risk that we face today, even though the numbers are smaller, it's reasonable for us to consider regional Australia as we have, I think.
Next, to welcome Olina.
All right, hello. Does the pointer work? Yes, fantastic. Great. So hello, everyone. It's a great pleasure for me to present this study to you today. I'm Olena Zotova. I'll be presenting a study that I conducted last year as part of my past affiliation with ICE Global Institute in Barcelona and Pompeu Fabra University, titled Developing a Theory of Change for Climate Change Mitigation in a Subnational Healthcare System in Europe, specifically focusing on the healthcare system of Catalonia. So I have to disappoint you a little bit. This is not a climate resilience presentation. However, I'm hoping that I can present an approach based on a theory of change approach that can be helpful for those who are working on climate resilience as well, and also integrating climate mitigation and resilience when we think about healthcare systems. Little disclosure of interest, I'm not affiliated with Pompeu Fabra University and ICE Global anymore. I'm a consultant with the Alliance for Transformative Action on Healthcare at the World Health Organization. And this being said, this study was conducted as a study nested in the European Horizon Europe Catalyze project, which you might have heard about as well at this conference. So the Catalyze project specifically, just a little bit of context, what it attempts to do is to produce and translate knowledge to stimulate climate action to advance healthy societies in Europe. And so Catalyze has a research agenda that's covering climate mitigation and adaptation. And as part of the knowledge translation work in that research consortium, the big question is really how can researchers make their research more impactful and really lead to the translation of research findings into practice, right? And this is a challenge that probably everybody who has worked in research is concerned about. So one of the major topics that we have when we think about climate mitigation and adaptation is when working with healthcare systems. We all know that healthcare systems are responsible to about 5% of global emissions. And so there is this need to develop and to improve quality of care while also ensuring that we reduce greenhouse gas emissions. So what we attempted to do is within the broad agenda of net zero healthcare systems, ask ourselves the question, how can we actually reach net zero healthcare systems in Europe, right? This ambition that is being discussed quite thoroughly. So we decided to focus on a case study in Catalonia as a starting point and try to answer this question, but not only focusing, when we ask the question how, it's not only the technological and the technical question, it's really how, what will it take from a social, from a political, from, you know, that very broad perspective. So the guiding approach that we decided to use and to try and answer this question is a theory of change approach, which some of you might have heard about. And basically a theory of change is a description of a sequence of events that is expected to lead to a particular desired outcome or change. So what people would usually do is they would think about what they would want to see in the future, what kind of long-term desired change, and kind of think retrospectively from that future change, what needs to happen in order for that change to materialize, right? So it's a very broad thinking that would be needed. And this usually results in some form of visual representation of change, so in the form of a sequence of events. You can also create a narrative explanation of kind of telling the story of how change might happen. And it's important to note that a theory of change doesn't really have a fixed result. So even though you might create an initial representation, it's something that would change as you advance in your project, as you implement more programs in your organization. And it's very useful to do strategy, to do planning, but also keeping in mind that it's something that can allow you to track your progress and to adjust as your understanding of the change process evolves. And it can look a little bit like this. So you would have the long-term desired change, then you can outline, okay, in what domains would we need change to happen? And then you can outline a sequence of events leading up to that desired change. And something also that's also important but not mentioned here because we didn't cover it in our particular study are some assumptions that you're making along the way, because of course you're hypothesizing of, according to your current knowledge, how could change potentially happen in the future. So all of this being said, the objective of our study broadly was to initiate the co-creation of a theory of change for climate change mitigation in healthcare at subnational level in Europe, integrating the perspectives of academic and non-academic stakeholders. So that was important, that we not only have researchers, but really some broad additional actors in the healthcare system that can provide input on what it would take to change the healthcare system, and really focusing on a key study of the Catalan healthcare system. And more specifically, we aim to define the long-term desired change we would want to see in climate change mitigation in Catalonia, to explain how this long-term desired change could be achieved, and to explain how knowledge production and dissemination can contribute to that process, so of particular importance to research efforts. So the study design was a qualitative participatory study. We recruited 13 stakeholders from broadly corresponding, I would say, when we think about knowledge, knowledge to action frameworks for implementation science frameworks. So we often talk about knowledge producers, disseminators, and users. So we wanted to have representatives from each one of these groups so that we have a diversity of perspectives on the process of change. And we created a theoretical framework based on an implementation science framework, the Consolidated Framework for Implementation Research, on a policy change framework, the Kingdom's Multiple Policies Change Framework. And we also integrated the 7 high-yield actions for climate change mitigation that were outlined by Healthcare Without Harm. All of this allowed us to create, so with a theoretical framework, we created a form of a canvas. So let's say a sheet that has several sections that we used as the canvas in co-creation workshops for stakeholders to come together in a virtual environment and try to discuss and draw out different events, different sequences that would lead ultimately to a desired change in climate change mitigation in the Catalan healthcare system. And this took the form of semi-structured focus groups. And we analyzed the data through iterative analysis and validation with participants themselves to ensure that we don't have too much researcher bias in analyzing the results. And we used the thematic and axial analysis as the analysis methods. So in terms of the results, so how can we achieve this ambition of net zero healthcare in Catalonia? In terms of the results, we were able to outline key categories of stakeholders. We were able to formulate the long-term desired change statement, the overarching theme of what would need to happen, and the sequence of events, and including categories and relationships between some of those events that would need to happen. So the key stakeholders, participants have mentioned many different local, European, Spanish actors that would need to take action towards climate mitigation in the healthcare system. We were broadly able to categorize them into the categories that you see on the screen. And in the subsequent theory of change, we were able to see where each one of these actors could be able to play a role in order for everybody to kind of work in the same direction of mitigating climate change in the healthcare system. The long-term desired change, as formulated by our participants, this actually would need to be updated. It's a smart net zero healthcare system in Catalonia. So this was kind of the broad long-term desired change statement that was co-created with stakeholders, saying that the healthcare system is smart, defined as a net zero healthcare system enabled by governance, multi-stakeholder participation and collaboration, finance, digitalization, knowledge production and dissemination, and of course setting the foundations of a healthcare system based on health promotion, disease prevention, that meets population needs for efficient, high quality, accessible, and equitable healthcare while supporting healthcare workers' occupational well-being. So it's a mouthful. It's a very ambitious vision for the healthcare system. It's in an ideal world, we would love this to happen. So how can we actually get there? And that was our challenge when co-creating the theory of change. So this is the broad representation of the theory of change that was at least that we started co-creating in that particular study. I apologize for the small print. I can zoom in a little bit more after. But the long-term desired change and the broad representation was on top over here. We identified the overarching theme of basically that top-down change and bottom-up change would be required. This is something that is often mentioned in many presentations, but we really wanted to emphasize this as a major result in our study and saying, yes, we need to be acting top-down and bottom-up at the same time in order to really create that momentum in the process of change. And then we had 4 core change pathways. So I'm just going to zoom in a little bit here. So the core change pathways are basically pathways of events that need to occur in the policy realm, in the industry realm, in healthcare institutions, and with healthcare workers. And so in each one of these pathways, we were able to detail sequences of events, and I'll show you an example right after of what that looks like. So a sequence of events leading up to the long-term desired change that was on the top. And we also noted that all of these pathways are very closely interlinked through, as you see in the dotted green lines, between the pathways through the supporting processes. So the supporting processes are those processes that enable, that can drive change, that can move things forward, but that also link those pathways together, that make it so action would be required really across these processes to stimulate change as much as possible. And these are governance, participation, collaboration, financing, digitalization, knowledge production, and knowledge dissemination. So this is probably not new to many of us who have been working on this. We really wanted to really set that stage, and also noting very specific events that need to be happening in each one of these supporting processes in this kind of coordinated effort towards climate mitigation. And finally, just noting that we were also outlined stages of change. This is, of course, a linear simplification of a very complex change process that is not linear at all in real life. But we still wanted to have an idea a little bit of what could be the phases that would need to happen across these pathways. So thinking of, okay, so in each one of the pathways, people need to be motivated, need to be committed, need to be planning for climate mitigation, need to work on implementation efforts, and need to work on monitoring and evaluation. So in detail, don't be scared. This is one of the pathways specifically. So that's the healthcare institution pathway that you see in blue. And in detail, this is a little bit what it looked like. So with stakeholders setting the long-term desired change here at the end of the arrow, we were able to think backwards. Okay, this is, let's say, actually, it's better if I explain to you from this side. So yes, so reading from left to right, seeing how we would start with pioneer healthcare institutions that are adopting climate mitigation measures, and then what would it take for more healthcare institutions to act, right? So gradually, what would it take to be more motivated, to be committed, to plan, etc. And what you see color-coded over here are those supporting processes that fuel into the change process. Oh, okay, that's the end of my presentation. That fuel into the change process. And so we really were able to outline what are those opportunities for different stakeholders to work on supporting processes to contribute to climate mitigation. So in conclusion, of course, it's a complex process with many interlinkages between sectors and stakeholders, but important to note that knowledge, what we really wanted to highlight is that knowledge translation would be needed in a multi-pronged effort. So really not only focusing on one particular stakeholder group, but what we saw is because everything is so interlinked, it would be most efficient if really we were able to target many different stakeholders that would all be able to play a role in that process of change. And so very important, making relevant the research to different stakeholders, right, through a variety of ways that were also outlined across the events that need to happen in our study. And using, finally, a theory of change approach can help approximate that sequence of events needed to achieve net zero healthcare and create those areas of action for stakeholders to act in a coordinated way and create those hypotheses of how change might happen that can then be tested through research and implementation in practice. So that's it. I want to thank, of course, all the people who have been involved in co-creating that theory of change and open the floor to questions if maybe. Thank you.
Thank you for the presentation. And I wouldn't underestimate, I think this is what those systems is about, is to have a theory of change and being able to plan and see how we can adjust the system in which we are working. So I was wondering, because when you have your overall goal, yes, it's very broad, but it's a good ambition, but you are talking about promotion, prevention, and really integrated care in general. However, when we see the theory of change, when we see the stakeholders, we see patients, we don't see people from the catchment area. So, and then we see healthcare, not health. So I was wondering if it was because you were thinking about a path through medical care and not necessarily health as a whole, because I think eventually in the theory of change that might have been an interesting finding to see, well, we don't need to take only to the patients. We need to talk about people in the catchment area for the health facility, because at the end you want to reach social governance and what about social accountability. So I think in a nutshell, it's like I perceive like a facility-based approach. So I wanted to know if that was intentional, and if so, if on the way you find a way to make it broader to health and to people and not patients and healthcare.
Thank you very much for the question. So to quickly answer that could be ground for further discussion. I didn't have the time to present. I only presented you the healthcare facility example, right, over here. But we actually, and I'm not going to cover the additional slides, but we actually had, the healthcare, the policy pathway. And this is where you might see a little bit more of that governance and what would need to happen in public health policy. And I'm sorry it's so small. It's just the theory of change was very detailed. But I'm happy to share materials afterwards if you're interested. In the policy pathway, there's definitely ways for the public health administration and community involvement as well. However, to be noted, and this is one of the limitations of our study, this is an initial version of a theory of change that's co-created with a limited group of stakeholders. And so we couldn't really insert additional elements unless they were mentioned by stakeholders themselves as part of the data analysis process. So there are many potentially relevant additional elements that, for example, the community perspective that perhaps were not sufficiently represented in the discussions for us to be able to identify them as one of the core, key categories in our data analysis process. But this is really work in progress. It's an initial version that the idea is to really enhance it also moving forward with additional understandings. Yeah, we can continue after. Yeah, sorry, it's that's it. Thank you.
Hand over to Ilonka. Thank you. My name is Ilonka Horvath. I'm working at the Austrian National Public Health Institute in the Competence Center on Climate and Health, which was actually established only in March 2020, but I think we did do a lot of effort to and great work. What I'm presenting here is a highly practical challenge we were facing when we were transferring a WHO framework on vulnerability assessment to a national or subnational implementation. Regional is actually a wrong translation, which I realized today. So we mean subnational on a very small scale. A few things, few words on the background. There are three aspects which are really essential for our work. One is that the impacts of climate change on human health are based on complex interrelation. So we have, on the one hand, some of the impacts on the health system itself are emerging quietly. So they are not maybe on the top list of in regard to urgency. And this is also in the resulting in a need of establishing awareness on policy level, but also a preparedness on different levels of healthcare systems. And third, that we are facing a multiple burden or double burden in a way that population groups which are already disadvantaged due to their somehow preconditions tend to be particularly vulnerable to climate-related health risks. So generally our aim works, work aims to identify those vulnerabilities and conditions of double burden by conducting a structured quantitative vulnerability assessment on a subnational level in Austria. And for doing so, we refer to two, for us, quite crucial WHO documents. The one is the operational framework for building climate resilient health systems, which you see on the left-hand side. And on the right-hand side, it's also WHO published a climate change and health vulnerability and adaptation assessment guidance, which is, for us, it is the framework where we are referring to. And this guidance also contains a six-step approach, and the second step is a vulnerability assessment, just to contextualize. In regard to the methodology, when starting to think on the implementation of this vulnerability assessment in Austria, we first had to decide on the spatial reference, spatial reference for analysis. So here you see Austria, like the Austrian schnitzel, as we always say, and the smaller pieces are the Austrian healthcare regions. They are slightly comparable with the NUTS 3. We choose this reference because it is used very much in the healthcare structure planning in Austria. This this reference helps us to map small-scale vulnerabilities and also enables a differentiated analysis. We know that there are always, like for Austria, because Austria is a very, very small country with a total of 8 million inhabitants, or 9 million, I think. There are a lot of trade-offs between small-scale geographic resolution and data availability. So this is actually the WHO framework for the vulnerability assessment we were using initially. It consists of 5 dimensions. Each dimensions are described by factors. And these factors are kind of giving the dimensions the substantive connotations. And so this was our baseline, and we tried to use this for a national implementation. So what we did in based on these 5 vulnerability dimensions, we started a systematic data mapping in national available databases, and following a cascade of 3 aspects somehow, you know. So the data mapping, the first aspect referred to the applicability of suggested vulnerability factor for the Austrian context. The second aspect was somehow the question, do we have suitable indicators that represents this vulnerability factor? And the third aspect was the real data availability on a small scale level. So after performing this, we identified the indicators. Actually, I can show you later, but we did a qualitative analysis calculating quantitative values for each indicator in relation to population or geographical area of region. And we also were calculating an Austrian average as a baseline for the comparison between the regions. And we were also trying to find good visualization. So as to the results, the challenges and also the solutions, you know. Applicability of vulnerability factors. For example, we found that in particular the socio-political vulnerability factors posed by the WHO framework are somehow tailored for countries, for example, with an unstable political situation or non-democratic structures, and they are not fully applicable for Austria. For example, freedom of speech is a factor which is not really suitable for the Austrian context. So we were trying to use or identify better suited socio-political vulnerabilities. I don't know if I hope you can read it on this little pizza slide. What we defined is possibility of political participation, political interest, social cohesion, and the feeling of regional connectedness. In regard to the identification of suitable indicators, we saw that factors like social cohesion and the possibility for political participation, for example, are hard to measure directly. You don't have a direct indicator for it. So we had to find and define proxy indicators. For example, we choose density of associations. Austria is a country with a lot of associations, in particular in rural areas. And we use that indicator to measure social cohesion, for example, or for the percentage of people with non-Austrian citizenship, we use as an indicator to describe the possibility of political participation. And the third aspect is data availability of indicators on regional level. We know that health, in particular health survey data in Austria is often not available on regional level, also due to the very small sample sizes. So we had to choose either different choice of indicators or data sources where we have better data quality, or we had to, we also were facing a limited access, in particular to geographic data, primary data, and we also there we had to either reduce the set of factors or extend it with in terms of the geographical factors dimension. We were using climatological factors to get a better picture of it. So this is the Austrian pizza. That is our adapted set of vulnerability factors. Just to summarize shortly, in total, we kept the 5 dimensions. We defined 23 vulnerability factors using 25 indicators, and we were actually using 11 different data sources, most of them outside the health sector. So this was our idea of visualization. On the one hand, for a comparison within Austria, that's the schnitzel again, and the right side is the visualization for on a very small scale sub-national level, where you see in the colored is the regional vulnerability in comparison to the gray layer, which is the Austrian average. Yeah, for the conclusions, assessing multiple dimensions of vulnerability is key to identify the pressure points and also the pre-existing inequalities in health burden. And we need to acknowledge the complexity in doing so. We see that the WHO framework is a useful guidance, but adaptation to the national context is required and poses challenges on the 3 levels in terms of applicability, the derivation of suitable indicators, and the data availability. We also see that there's a need of multidisciplinary teams to fulfill this task. Also, due to the multitude of data sources we needed for describing the vulnerabilities, and there are further improvements in the visualization required. We are currently working on designing a circular bar plot, which you see on this side. This graph is also used to describe the planetary boundaries, and I think that for us it would be a suitable way to present. Yes, thank you. And I also want to thank my colleague Felix, who is in the room and who did great work. Sorry if I missed this, but are you using the data from these no. If we are using the data from our National Health Adaptation Plan, actually, we don't have in Austria, we don't have a national health adaptation plan yet. I think this is something also we are trying to achieve, but yeah. But I think this could be a super good baseline, actually, also for to fill information and data in. But on the other hand, we also choose the very small scale subnational level because we think that also in terms of adaptation measures and the implementation of measures, we think that using like a small scale geographical area is a good lever to really start make a change with the population itself. But that's another story. Thank you.
Let's welcome our next speaker, Chris Turner.
Thank you. Hi everyone, I'm Grace Turner. I'm a research fellow at the London School of Hygiene Tropical Medicine, and today I will be presenting some work as part of ENBEL's Work Package 4, which looked at stakeholder mapping, and this study was particularly focused on the barriers and the levers for implementation of climate and health adaptation in Europe. And just to say thank you to all my colleagues that were involved in this work. So I think we know by now, as we've heard over the last couple of days, that climate change is having and will have significant implications for population health and well-being. And we've heard already lots of examples of climate adaptation policies that are being implemented across Europe, varying from the national, international, and also at the local level. This is driven by high-level political action, public support, climate activism, and the increase in intensity and frequency of extreme weather events. And in the context of this piece of work, we were interested particularly in the barriers. We've kind of identified from previous literature that the barriers that are limiting implementing adaptation also seem to be the same barriers for public action. So to put this piece of work into context, in 2021, the European climate law was passed, which commits the European Union and member states to make continuous progress to boost adaptive capacity, strengthen resilience, and reduce vulnerabilities. And all across the EU, there are a lot of examples of national climate adaptation policies that are being implemented. As of now, not all EU countries have a national adaptation policy plan or programme, but many are implementing those. However, the amount or the level of public health that's being implemented into these policies is still relatively limited. And overall, the implementation of climate adaptation action in the public health community is underestimated. So we wanted to identify potentially some of those barriers and also those facilitators or policy levers that could be adopted in the future to support this. This is just an example of a potential missed opportunity for implementing climate and health adaptation. So following the COVID-19 pandemic, the EU released the Next Generation EU Recovery and Resilience Fund to support the economic recovery of EU member states following the COVID-19 pandemic. The purpose was to increase or improve the resilience of health systems and also to progress each EU member state on their green transition. When we actually reviewed all of the different resilience and recovery plans that the member states submitted, and part of that was they had to make commitments, and over nearly all of the commitments in terms of the green transition were mitigation actions, and only 6% across all member states in terms of the commitments were addressed to climate adaptation, and even less of those were specifically addressing public health. That just shows it was a potentially missed opportunity. So for this study, the aims and objectives were to firstly identify key issues in climate adaptation implementation for public health in Europe, and then explore those barriers and policy levers. And we did this through a thematic analysis of key decision maker interviews. We interviewed 32 decision makers, and these ranged in, they may be public health professionals working in environmental health or adaptation leads. And these are in the international, national, and the majority, admittedly, were city level governments across 20 different European countries. And just to keep in mind, this was between June and October we did these interviews, so things may have moved on slightly since then. So on analysing the transcripts, these were the 5 key themes that we identified from the interviews. Firstly was, I think as you would expect, a topic around aligning the climate and health agenda. Secondly, there was a real focus on the importance of governance for adaptation. One that I think we would always expect to see is the issue of funding needs and capacity requirements. Probably the most frequently reported issue or facilitator was the importance of intersectoral working and cross-collaboration, and then also thinking about operational knowledge and data mobilisation. So I'll just talk you through each 5 of these in a little bit more detail. So firstly, as you can see here from a city level interviewee, the penny is dropping about the importance of health as a lever for climate action. And sort of at the very top level, it was frequently reported that the importance of including health professionals in implementing climate adaptation strategies and interventions is a key facilitator for doing this. And potentially a way of doing this is integrating health in all policies as a way of introducing adaptation across all sectors. And as of, this was 2021, but I think it still is relevant today, but most interviewees reported that health is rarely included in climate adaptation policy. So then moving on to governance for adaptation. So, and as you can see, this was one of the quotes from an international government representative who was talking about engaging with policymakers from the local level up to the national level, and the way to engage them in terms of climate and health adaptation was to show them evidence. So potentially that's a way we need to enhance the government, or to introduce evidence is a way of motivating the government to introduce remits, whether that be at the national or the city level. But we've identified that having real impact experience in their either country or city or region was able to then mobilise them to really think about this issue. A key lever then, reportedly, particularly at the city level, was having a national remit that they could then respond to, particularly in terms of resource allocation. And many cities seem to actually be doing more than their sort of national governments in terms of their policies. A couple of different cities, particularly, and then maybe the few national interviewees reported that they're introducing new roles, being adaptation leads, although these still don't necessarily have a health remit and don't sit within the health department. And finally, the issue of political leaders. Sometimes they're really supportive, but more often than not, they undermine adaptation strategies. So it's important about thinking about they're a key actor within this space. Thirdly, possibly the most obvious one in terms of a barrier is the importance of funding. And an international interviewee actually reported that it's hard to entice policymakers or funding. But then if you introduce a conversation and the argument around health, it immediately improves, it adds the value to the argument and seems to be mobilising and motivating those groups. In terms of at the city, an issue is we're asking them to introduce another sort of topic or theme into their public health service, but they're not getting any extra funding for that. And they're already burdened with so many issues as it is. So it's thinking about the support that's needed from the more senior or central government. And following on from that, we actually interviewed a few city climates networks, and one talked about, in terms of adaptation and health, there's probably only one or two in the whole city level government that has the remit to work on this. So we need to think about the capacity and what we're asking of them to do. Then moving on to the intersectoral working and cross collaboration. Across pretty much every single interviewee that we spoke to, talked about the importance of interagency, intersectoral, interdepartmental, intergovernmental in terms of implementing real action. And in terms of engaging the mitigation people, the adaptation people and the health people, there still are silos that are persisting, preventing that sort of interagency and interdepartmental work, which is what we really need to see the change. And actually, a few interviewees pointed out the ideas of grants and funding actually allocating or only allocating groups that actually are using an interagency approach. So that's potentially a way that we can improve this in the future. And then finally, thinking about operationalizing knowledge and data mobilization. And our City Climate Network talked about making a stronger connection to academic work. However, many city level, particularly representatives, talked about it's not necessarily accessible, or if it is accessible, it's not being operationalized into policy. And that might be due to limited time, capacity, or awareness that it exists. And most are accessing WHO information due to the nature of it being easy to access and sort of a central repository to do so. So we need to think about that when we're writing our journal articles, how we can make them the most accessible. But there is still a sort of a gap and a range in terms of the knowledge across Europe when we're speaking to it, depended on the governance level, the role and the region in terms of their knowledge in climate and health adaptation. So it's about sharing that knowledge between these groups. And finally, particularly because we talk to a lot of cities, it appears that engaging in public health networks was a key facilitator for sharing that knowledge around climate and health adaptation. And particularly the WHO's Healthy Cities Network was seen as sort of the gold standard of doing that. So just to finish off, we've sort of adapted the WHO Healthy Cities Network sort of framework to sort of identify and pull all these results together. And so firstly, thinking about sort of off the back of the EU Resilience and Recovery Funds, moving into a digital transition appeared to be quite a common commitment. And I think it's only going to go that way in the future. So thinking about making our digital and our healthcare systems more resilient. It's always important to think about inequalities and targeting vulnerable groups, as they're increasingly going to be the most adversely impacted by climate change and health. as I pointed out earlier, the importance of interdisciplinary collaboration cannot be stressed enough. It's sort of the optimal way that we can work together to improve climate change and health. Improving data and knowledge mobilization, having actually possessing a government and having the governance and the remit to act, which then leads you on to hopefully having improved funding allocation and capacity building. I think, yeah, that was my last slide. We've submitted this to the European Journal of Public Health, and thank you very much. I wish I could answer that, but that would be going against the ethics, unfortunately. We would love to be able to map some of this in terms of across Europe, but that would not comply with our ethics. Sorry, what was that? I would say the countries that are part of the cities that are part of the WHO Healthy Cities Network appeared to be sort of at the forefront of a lot of this and are supporting some of those cities that are less informed or have sort of the less capacity and resource allocation. So that seemed to be fun. Glasgow, Sherry's telling me to say. But yeah, that seemed to be sort of a really key tool for you for furthering this agenda.
We don't know how well it's been implemented, but we wish to take that work forward still in future. But that's something that you might want to check if you need some kind of tips what could be included in those plans. One more question.
Thank you, Chris. It's really interesting. Just as picked up on your point about sources of evidence that actually people could generally go confidentially directly to the WHO. And I just wondered if that's because they knew they'd find that information there, or was it to do with the way that that's presented, whether you unpick that anymore? But that's quite a limitation, isn't it?
I think it was a bit of both. I think, okay. It was a question about whether that's these interviewees are accessing the WHO because it's sort of what they know, or whether there's any limitations around that. And I think it was a bit of both. So they were really familiar with the WHO, and there is sort of a central repository in a way. It's a place to access all information on a topic. It's an easy way to search a particular topic you're interested in. But also they did report that it's often they don't know where to go for sort of academic literature, and it's often in really technical jargon, and it's long. Typically it was that it's really long and we need really short, two-page technical briefs is sort of what all the time they've got for, and WHO facilitates that in the way that they present their evidence. So I think it's not that we don't pursue with academic literature, but we also think about additional ways to write up this information and where it should end up in terms of these key, obviously, institutions and organisations that most of these interviewees and cities particularly go to, because due to just limited resource and time.
Thanks very much.
Hello, everyone. Can you hear me? Yes, that's okay. Yeah, so I'm Cherie. I'm a research fellow at LSHTM. And for the past few years, I've been working as part of the CHAMNA project. And today I want to present one of our recent studies looking at the effects of ambient temperature on risk of adverse birth outcomes in South Africa. So approximately 1.9 million babies were stillborn in 2021, 45% of which occurred in sub-Saharan Africa. Close to half of all stillbirths in sub-Saharan Africa occur during labour, known as intrapartum stillbirths. And the majority of these fetal deaths are preventable with access to high quality healthcare at the time of delivery. Each year, an additional 13 million babies are born prematurely, and this is the leading cause of under 5 child mortality and accounts for more than 1/3 of neonatal deaths worldwide. So despite recent improvements in healthcare, rates of preterm birth have largely stagnated over the past decade, and South Africa has the 5th highest rate of preterm birth globally at 13% of all live births. Now, there's already substantial evidence that exposure to high temperature during pregnancy is associated with an increased risk of stillbirth and preterm birth, with most studies reporting an acute effect of heat. However, the vast majority of research has been conducted in high-income countries, with evidence still lacking from sub-Saharan Africa. Because of this, we know very little about how and if heat exposure impacts on intrapartum stillbirths, because the vast majority of fetal deaths in high-income countries occur before the onset of labour, so before the women arrive at the healthcare facility. We have limited information on the role of individual risk factors, particularly chronic conditions such as HIV. And there's also been little research on other perinatal health outcomes. So, for example, APGAR score is a quick physical test. It's used globally to assess the health and vital signs of a newborn, and with a low score indicating that immediate intervention is required. So we set out to fill some of these gaps, evaluating the short-term effects of ambient temperature extremes on risk of stillbirth, preterm birth, and low APGAR score in Soweto, South Africa. So Soweto is a densely populated, low-income urban settlement southwest of Johannesburg. It has a temperate climate with warm summers and dry winters. Our study population was all singleton births between 20 and 44 weeks gestation, recorded at 10 Soweto healthcare facilities, 1 tertiary referral hospital, it's a huge hospital, and then 9 smaller midwife-led clinics, and this was over 6 years. Our primary outcomes were stillbirth, live preterm birth, and low APGAR score in live-born term infants. Our secondary outcomes were subcategories of stillbirth and preterm birth. So we used data from all 10 facilities to identify cases of stillbirth in low APGAR score, but for preterm birth outcomes, the data were restricted to the tertiary referral hospital only, given the higher quality gestational age information in this facility. So in this population, we see a stillbirth rate of 2.2%, 37% of which occurred during labour. Very high preterm birth rate, but remembering that this was based on births, the more complicated births at the tertiary referral hospital, and then a low APGAR score rate of 0.5%. Our primary exposure was daily mean temperature using ERA 5 land gridded data, with exposures assigned by date of delivery and location of birthing facility. And we used a time-stratified case crossover design where cases serve as their own controls. So here we're essentially comparing a woman's exposure on the day of the health event with that same woman's exposure on otherwise similar days when the health event did not occur. So control days were defined as the same day of the week within the same month and year as the case. And then this implicitly adjusts for potential day of week effects and seasonality. In terms of statistical analysis, we use conditional logistic regression following a distributed lag nonlinear framework with a 6-day lag period, so focusing on the week leading up to delivery and the day of birth. Models were adjusted for dew point depression as a measure of humidity, and low and high temperatures were defined as the 5th and the 95th percentiles of daily mean temperature, respectively, over the study period, exposure to which was compared with the temperature of minimum effect, so the temperature at which we were seeing no impact. We undertook various subgroup analysis on our primary outcomes, and then we also looked at potential effect modification by facility type with the intrapartum stillbirths, so looking at the primary midwife-led clinics versus the tertiary referral hospital. And we estimated that overall, the odds of stillbirth increased 1.21-fold with exposure to 22.5 degrees Celsius, the 95th percentile, versus 19.5 degrees Celsius, the temperature of minimum effect, 0 to 6 days before delivery. So risk increased significantly above 21 degrees Celsius. So not as extreme high temperatures as you might expect. And we also found that the heat stillbirth association was consistent with the timing of the fetal death. So looking at the antepartum stillbirths, we see an effect of high temperature on the days leading up to delivery, so it lags 2 to 4 here. And then with the intrapartum stillbirths, we're seeing a tendency towards an increased risk with heat exposure on the day of delivery. Now, this included all intrapartum stillbirths at all facilities, but whenever we stratified by facility type, we see a much clearer association with high temperature on the day of delivery in the tertiary referral hospital, so as you can see in the top figure here. And we saw no associated risk with same-day temperature extremes in the midwife-led clinics. Then considering all stillbirths for the main subgroup analysis, not surprisingly, as you can see on the right, we saw, oh, I'm sorry, that's a little bit unreadable. But we saw, not surprisingly, we saw an effect of heat in the summer season when absolute temperatures were higher, but also an effect in the autumn season when absolute temperatures were somewhat lower. And interestingly, we saw no adverse effect in spring, even though the temperatures were high. Whenever we stratified by infant and maternal characteristics, we see an increased risk among all subgroups with exposure to high temperature, but male fetuses, women under 35 years, nulliparous women, and particularly women living with HIV were at greater risk than their counterparts. And we also find evidence that low temperature was associated with an increased risk of stillbirth among nulliparous and HIV negative women, but not among multiparous or women living with HIV. So then moving on to preterm birth, we find that overall risk increased 11% with exposure to high temperatures on the week leading up to delivery, with risk significantly increasing as temperatures rose above 20.5 degrees Celsius. And we saw the strongest association at lags 0 to 1, so the day of birth and the day prior. And we saw a similar pattern across all subcategories of preterm birth. We saw that risk increased with exposure to both high and low temperatures in the autumn season. And interestingly, we didn't see an increased risk with heat in the summer season when absolute temperatures were higher, nor did we see an increased risk with low temperatures in the winter season when absolute temperatures were lower. We saw a consistent increased risk among all subgroups of infant sex, maternal age and parity. But again, we see that women living with HIV appear to be at greater risk with heat exposure. And we see that only women living without HIV may be at increased risk of low temperature effects. And you can see on the figures on the right that at lags 0 to 1, women living with HIV appear to be at greater risk. We see a stronger association there. But more notable, we see this increased risk of preterm birth among HIV negative women when exposed to low temperatures a few days before delivery. And we don't see that among HIV positive women. And just to mention, we find no evidence of association between ambient temperature exposures and low APGAR score. And we ran multiple sensitivity analysis to check the robustness of these estimates, and we find that they were very robust to all the changes in the models. So overall, our findings are consistent with an acute effective heat exposure on risk of stillbirth and preterm birth. I think for the first time, we show potential effect modification by HIV status. We also show that high temperature on the day of delivery appears to increase risk of intrapartum stillbirth, particularly among the most complicated births. And now this may be that heat increases the risk of pre-existing complications or may introduce new complications, but it also might be because of indirect effects. So It may increase demand on services, or it may also impact on the healthcare workers themselves. So we had a number of study limitations. We did only focus on the short-term effects. We didn't look at the chronic exposures or earlier exposures. Sorry, my mouth's really dry. We had a small sample size for stillbirth and low APGAR score. And then we are aware that there's a high rate of non-nationals accessing services in the province. So that could have led to, thank you, Sherry, that could have led to some exposure misassignment, but women accessing services from elsewhere are likely to have arrived in the area kind of some weeks before delivery and not on the day of birth. So our focus on the short-term effects was actually probably quite beneficial here. So in conclusion, high ambient temperature is associated with an increased risk of stillbirth and preterm birth in a high burden, low income setting. Acute adverse effects of high temperature are not restricted to the hottest months. Future research should consider the potential role of maternal HIV status, and research is needed to evaluate the impacts of heat exposure on quality of care. So I just want to thank my co-authors and our funders, and thank you for listening.
The different association that you found between tertiary care centers and midwife centers is very interesting. How there seemed to be no association between what was it, stillbirths and high temperature or was it preterm?
It was the stillbirths. Oh, sorry. Just saying that, asking about the association, the difference in association between tertiary and the primary care. Yeah, so what we think it potentially has happened that if a woman comes into one of the midwife-led clinics and there is a complication that develops, she will then be referred to the tertiary hospital. So she'll be transported from the primary care clinic into the tertiary hospital. So we think that actually that is why we're seeing no, and actually there was almost a tendency towards a reduced risk. So we think that's the reason why. Yeah.
I just noticed that you had the extremely premature babies. There were quite a high number in your data set. It was around 7% by calculating in my head. It was 1,300 out of 18,000 or something. This is a little bit higher than I'm used to because these babies are normally less than 1 kg. And they're very, very sick. It's really the ones that we want to avoid being born.
Strategies, and also a lot of people in the room felt like they had limited knowledge on how to actually access the funding that's out there. And also the application process was very complex for them to understand. And as usual, there are always competing priorities when it comes to funding. You know, the policymakers also felt that there were no opportunities for scientists, and they were actually very appreciative of the fact that we had researchers in the room, because they were saying there are not many opportunities for the scientists to connect with the policymakers, and also for the policymakers to give input into research prioritization, because we tend to come up with a research agenda without getting input from the policymakers. So they appreciated that, and also the translation of that research into policy. We talked about lack of collaboration between the different ministries, and funding being a barrier to implementation, and lack of skill and capacity. And some countries were left behind, as we heard in Caroline's presentation before. There some countries, actually Julian, some countries who have heat health guidelines where others have not yet started developing those. So we took those conversations into the conference in Botswana this year. And so what we did a bit different was that we started we brought people to come in and talk about what they're doing in their region to address some of the issues. And we've had interesting discussions. We had people come in to discuss case studies on how they manage heat risks in a specific area. We had research that's ongoing in the Sahel region on coastal city resilience. Also, we had someone talk about adaptation to extreme heat in hospitals in Ghana. We also had interesting discussions on climate-sensitive infectious diseases in Africa. Prof. Moyo talking about how climate change is increasing the risk of epidemics and gives pathogens advantage in the African region. We had the WHO Attach Initiative from WHO Afro, looking at, it's looking to support countries to deliver on commitments for climate resilience and healthcare sector decarbonization. And then we also had Matthew also talking about climate financing for health systems. We also talked about progress. We had a panel where each country talked about, what progress they've made in terms of adaptation. We talked about, cross-sectional approaches for population health, intersections between climate, environment, and health, future directions. There was a lot of emphasis on the fact that mental health, climate change and mental health in the African region is a problem and it needs to be addressed, and also looking at health systems research for climate adaptation. We used the opportunity, as I said, for networking and partnership. It was great when people say, this is what I'm doing, join me, and let's grow the network even more. Sorry, this went down, but this is we had a session on, what do you think are priorities for climate resilience? And I won't discuss the whole slide, but priorities range from research, education research, capacity strengthening, infrastructure, finance came up a lot, and then also guideline development. So just some of the highlights from the session in terms of what people thought were priorities. It was very engaging and very exciting. We had a closed session for the non-network members, or actually for the network members, even though the non-network members were in the room, to kind of like, how can we best support you as a Chance Network? What do you need from us? And issues like capacity development was very strong. Access to finance was also kind of like came up a lot, as you can see. And also, I won't mention them all, but, mapping out priority themes and, for fostering global connections and, something like this for the Chance Network members. And just out of interest, in the first conference, we had an exercise on research prioritization, just to get from policymakers what they think are priorities in terms of research. And again, I suppose this is like research into how to access climate finance, policy and health services were the top priorities. And also in terms of what they think about policy guidelines, building climate resilience and environmentally health facilities was a priority for them. And second priority was developing early warning systems for heat waves, and air pollution was also problematic for them. And so they felt that it's something that needs to be addressed. In terms of next step, we want to obviously develop strategies to address the issues. They told us what the issues are, and it's up to us to make sure that we develop strategies to address those race issues and those priorities. Also, implement tangible and practical steps, to show progression. We don't want to walk into the third conference without having addressed this, because we will lose momentum. So we want to be able to show progression. We want to widen the membership network to bring in more people from the African region. We started with Eastern and Southern Africa, and we now expanded towards the West of Africa. We want to enhance networking opportunities in between the annual meetings. So it's not just about the conference, but in between, how do we make sure that we connect and we continue the conversations? But obviously, to be able to do this, resources are key. We need funding to be sustainable. So I'm standing here saying, please, if anyone knows of any donors, we are here. Please, fund us. And I just wanted to say that for all those of you who are interested, be on the lookout for the next annual Chance Network conference. We will be letting you know when that is going to be. And we have a website where you can go in. That's when we have confirmed when the next conference will be, that information will be on our website. And with that, I thank you.
You did it. I told you. Nearly the end of our session. We've got time for questions. Elena? Just very quickly, are those results that you presented, the prioritization exercises and others, are they included in a publication somewhere or accessible
Yeah, so the question is now looking at EGO, whether the findings from the research prioritization exercise are included in publication. We're in the process of trying to do that. We're trying to get ethics waiver because to be able to publish the results. Yeah, so hopefully soon. Yes. Yeah.
Where can we find on the ENBEL?
Yeah.
On the ENBEL
Yeah.
website. Thank you.
Probably this would be more of a comment, but I'm thinking that in more of the chance network, we should consider, because I feel like in the health sector, we are more the recipient of what happens due to climate change, but including more multi-sectoral people like from the environment, from the agriculture, from all, because it's such a huge area that we tend as the health sector to be the recipient that, more visible to us that this is actually affecting the human. But unless we bring together many more who play key roles on the table, then we will have such an all-round, well-managed antidisciplinary sector.
Yeah. Certainly, the comment is that there should be a multi-sectoral approach that brings in multiple disciplines. And absolutely, I've been in rooms where this is beyond the scope of just health, and we are now bringing in all the other disciplines into the room to look for, to collaborate and look for solutions together. Absolutely, thank you.
Finishing on time. So we'll just, I think that's been an excellent session, but we should all thank our speakers again. And, yeah, thanks, and enjoy the rest of the conference. Not there's much left. But.
Right.
That is like leave your questions about